This is Augusta DeLomo on February 27th, 2025 at 9:29 a.m. in Atlanta, Georgia, conducting an interview for the Global Oral History of PEPFAR project. To begin, could you start off by introducing yourself and establishing your connection to PEPFAR and what years you worked for or in partnership with PEPFAR?
Good morning. I'm Rebecca Martin. I am currently the Vice President for Global Health at Emory University and the Director of the Emory Global Health Institute. I worked with PEPFAR in the field from 2004 through 2006 and based in Atlanta from 1999 to 2002. And then as well from 2015 through 2021, based in Atlanta. So here in Atlanta, first I was working in the surveillance and working in establishing how we're going to measure prevalence, incidence of HIV. And then when I came back as the director for the Center for Global Health at that time, it was in one of these programs within the center that I led and oversaw. In Tanzania, where I served for PEPFAR, I was the director for program implementation, human resources, and workforce development. So it was a conglomeration, but in effect, I pretty much served as the deputy for the whole program in many ways while I was there.
And Dr. Martin, could you tell us briefly about yourself and your family? Where were you born? Where did you go to school? Things like that.
So that's not an easy question. I was born in Bangkok, Thailand. I grew up, my father was with the State Department, and so we grew up in many different countries in Asia and Africa, and came back to the United States to go to university. So my parents are originally from North Dakota, and he moved overseas and my mother went with him, and from that was a whole career, but having lived in multiple countries and finishing high school in Kenya before coming back to go to university in the United States.
Can you tell us about how you got into the field of public health?
I think it came from my upbringing, from having lived in many countries. And I always go back to when we lived in Afghanistan and we were going to the market on a Saturday afternoon, and you would see people paralyzed by polio. I didn't know at the time it was polio, but I saw paralyzed people and children sitting there asking for funds or monies. And it was at that time that my interest is how can we help people? And throughout that, I went more in my schooling as well, even in high school, went more towards the sciences. I wanted to see what were the causes of diseases and how do we help stop them.
And how did you come to work on HIV and PEPFAR specifically?
So I had worked at the Maryland State Health Department, and I came here to Atlanta and started an immunization. And that had been an area I felt thinking about the value of how do we prevent disease. Vaccines are the ultimate way to prevent diseases and the most safe and effective way to do that. So I came here to do that, but had always, even in Maryland and even in the late 80s, hearing about HIV, hearing about AIDS, and learning about it in schools, and knowing more and more about that. Even at Johns Hopkins, where I went to school, my studies were part, and also my the graduate research assistant work had been working with professors working in HIV. And so the value of that was so important, and seeing what we needed to do and seeing that countries were going to have negative growth rates, and the value of that this was actually going to destroy countries. Here was a disease. It wasn't a war. It wasn't guns or metal, but it really was a bug, a virus that was doing this. So within that, coming to CDC, I came here for immunization, but when had an opportunity to work in the global HIV program, I applied and jumped into that. And with my strong background in surveillance, started to think about how we work on surveillance. How are we going to be able to detect? How big is this burden? How many countries are involved? How do we detect it? Because if we're not able to detect it, we aren't able to stop it. So that was my interest in that. And it was actually before PEPFAR had started, about a year, and then LIFE came about. And so I was part of establishing LIFE here at CDC as well. And then that grew into the Global AIDS program, and then the President's Emergency Plan for AIDS Relief. But through that, it was sort of, we were hearing that there's going to be funds coming, we're going to be working in X number of countries, what can we do? And so we were working at that time on antenatal clinic surveillance, the introduction of rapid diagnostic tests that could really get you the results quickly and that people would be able to know their results fast. They didn't have to wait 2 weeks to hear. So this was what brought me in, and really what has sustained me in that is the opportunities that it is such a multifaceted approach and what is needed to stop the AIDS epidemic.
We had the pleasure of speaking with Ken Castro, and he talked to us a little bit about the LIFE initiative. Can you walk us through what was LIFE's early purview, and how would you describe it as similar or different to what became PEPFAR?
Oh my gosh, it truly grew. I think LIFE was, as I said, I think we started with maybe 13 countries thinking they were going to get additional funds. And we heard about this coming from Washington because we're based in Atlanta. So there's always that delay and lag in hearing about things. But it was really to think about how would we start to think about helping people, like first detecting HIV, and then what else could be offered to people who had HIV. Because at that time, treatment was not being given as a routine. The availability of treatment was not there. It was only available to some and not all. Stigma was high. And so really thinking about what could we do, given our strengths, and I mean our as CDC, what were our strengths to be able to bring to the table here? And thinking with USAID, what were their strengths? And it was really at that time, it was USAID and CDC. But over time, and as you see, it engaged Peace Corps, it engaged Department of Defense, very quickly Department of Defense, knowing that there was a large epidemic occurring among military as well, and then bringing in other economic components of the US government as well. So there was a lot of different areas that came into there, but initially it was USAID, and then what could CDC do to sort of come with them and bring that in, yeah.
What would you say are, when you think about the particular strengths of USAID and CDC, that you see them operating a lot in partnership, but they do have different strengths and skill sets. So at this time, what was the USAID purview and what was CDC doing?
I think this is what we were trying to figure out. And before that, how CDC and USAID had interacted was CDC had done consultancy work or had been embedded in USAID. We had colleagues that were in Malawi working in HIV, but they were doing it through the USAID office. So this was like the first time globally for CDC to actually have funds to do something with its strengths. And we think about, there's a lot of strengths of CDC given here. You've spoken with Joan O'Merman about the domestic HIV/AIDS control programs and epidemic efforts. So I think we had so much knowledge here that we could bring to the table as CDC. But in addition, we thought, we were the technical agency, we were the scientific agency, and thinking more about, while there's a lot been done in the US, that was some of the more social areas were led by USAID. But this has always been tension throughout the entire program in countries about what programs belong with which agency and how is it going to be decided. There were efforts to divide it by geographic areas in the country and say, USAID, you have these 3 provinces, and CDC, you have these 2. But it really doesn't play, in my opinion, doesn't play to the strengths of the agencies. And where I think about USAID and its development and opportunities, innovation, and areas that we don't have those strengths in with CDC, how do we bring those in and then bring in CDC strengths in the sciences, in the treatment, and so forth, yeah.
One of the really interesting things I would say for me about PEPFAR is how successful it's been, how large it's been, but how few people actually know about it. And so how would you explain PEPFAR to a layperson who's never heard of the program?
Is this somebody in the United States?
We'll say they're in the United
States.
Yeah. Yeah.
Because I think you get a very different response in some countries. Yeah. People know that they themselves or their family have been saved by being able to have access to drugs. But how I would describe HIV is, it is a disease caused by a virus. I think it has to be very clear that this is a viral infection. And once it affects somebody, it attacks your immune system, your ability to fight other infections. And so you get multiple other diseases that you would not get if you were healthy. And it is spread through blood and through bodily fluids. And so making sure that you're being safe with that. But those are the important things, is that this is, now we can say, I mean, with treatment, that you can live a long life with HIV. And with PrEP, using the treatment as a, before infection can really help. We've learned that actually treatment is prevention now.
One of the things that we were really interested to hear about was, you mentioned that you were hearing rumblings, right? Something's coming down the pipeline in Washington, and I believe that you're in Kenya when PEPFAR is announced. Do you remember the announcement? What did it mean to you and other people who were working in that environment of, okay, what is this program and what is this going to mean?
Yes, it really was sort of like, what is this going to mean? What does it mean for our work, our opportunities? How can we engage? And I think too, it was sort of thinking about, how long is this going to last? I mean, is this going to be another 5-year initiative? And one of the things I think we very much appreciated at CDC was that the funding went under U.S. Department of State. Because as I said before, most of these large initiatives like this would have been through USAID, but here gave an opportunity to have another very important player, Department of State, using the diplomatic components. So it was very exciting to think about, okay, now how are all these people in different groups going to work together? How do we engage with this? What does it mean for our work? And how are we going to start to develop long-term programs? Because it was very exciting to hear it was like multi-year money, that there was big money coming that could really make a difference and affect people's lives and improve people's lives.
Can you tell us a little bit about what led to your appointment to the WHO Africa Regional Office in Kenya at this time?
Yeah, so I was based here. I was LIFE, and we started the Global AIDS Program. And I was contacted to say, we're trying to eliminate measles in Africa. And we'd really love for you to come lead the East Africa. It was 8-country effort. How we're going to start to roll out vaccine to eliminate measles in 8 countries. And I couldn't resist that. What an opportunity of life to actually collaborate with 8 countries and think about their plans, but really massively knowing how effective the measles vaccine was, that we could save lives. So I was very excited to be able to do that. Also, having learned what I was doing with surveillance and HIV, bringing that to the table as well as we started to work with countries. There's always the overlap of all the work that we do.
Could you tell us a little bit, and obviously you primarily brought in to look at measles, but what was the state of the HIV epidemic across this region as you saw it when you got there? Maybe some of the unique characteristics of the things that these countries were dealing with that you saw as, okay, these are different kinds of priorities.
Yeah, so for some we didn't, like Burundi, we had no idea what was going to be occurring. And we had no information because we weren't there. And so that was one, is like, what's going on? We don't know. Rwanda, we had some information. Kenya, again, we knew there was mass occurrence of this, and we knew that deaths were occurring, and there were a lot of deaths, but we didn't know, we weren't able to actually calculate all the things that we were able to do as we move forward, and being able to quantify this, because it's important, and also understand there wasn't a lot of testing going on, and we really needed more of the testing occurring and counseling and getting people, to make changes with their, sexual behaviors. But in addition, then when treatment became available, how to do that. But it was a pretty, just trying to sort of whack-a-mole, I think I would describe it, is like, you have this one, okay, we'll work on this issue, we'll work on that issue. And there was no sort of like coherent plan. It started to develop, and it was a lot of goodwill and good science that came together to make that happen. But initially it was very much sort of, there were so many, as I said, multifaceted. It's like you could work on so many problems and issues. And thinking about stigma, I think that was a really big one. People were shunned, and the nurse workforce did not want to necessarily work with patients who they thought had HIV. And so there were a lot of these issues occurring at the same time, yeah. But it was mass. I think, thinking about Tanzania, Uganda, Kenya, we knew this was occurring quite rapidly and growing. We didn't have as much information from Burundi or Eritrea. Ethiopia is another one we knew, yeah.
I'd like to circle back to something you mentioned earlier about being excited that the funding is going through state and that it's multi-year. And obviously when you're on the ground, you don't see the whole picture. But one of the things that we've heard a lot about is how PEPFAR was designed as a new kind of foreign aid, that it was going to be something where it was going to be very much directed through U.S. institutions. It was designed to be, somewhat separate from the Global Fund with more American oversight. And I'm curious if you had any sense of, the reaction to that. Was that something that multilaterals were frustrated by? Like, do you have any sense of that early on?
Well, I can talk about in Tanzania, definitely, where many partners, World Bank, Global Fund, were doing what was called, Tanzania had a sector-wide approach, and so they had basket funding. And those groups, and Netherlands and the UK, were putting money into the basket. We, as U.S. government, were like, no, we're not. Our money is very specific. It's for this, and we're going to do that. And so we'd go to meetings. They have no idea where their money went, or they couldn't show the impact. So they wanted to go on field trips, and they wanted to go see what was happening. And in PEPFAR, we knew what was happening because we were out in the field, and we were directing our dollars and our money to actually having direct impact on the work we were doing, even with the ministry. I don't want to say we didn't cut the ministry out, but with the ministry, but it was very directed. And so there was that difference of approach, but valuing what we were doing and how we were doing it. Yeah.
When you talk about direct impact, like what were some of those things in the early days that you saw as like these were our priorities early on?
Early on, and I'll talk about Kenya. We had a visit from, at that time, HHS Secretary Thompson, Tommy Thompson came out, and I think standing up clinics for people living with HIV and getting people on treatment and going to voluntary counseling and testing sites. Seeing this was so important, and actually the impact it had on changing people's behaviors and getting people. The other one is the mother-to-child prevention, mother-to-child prevention. And seeing there where in Tanzania we worked on early infant diagnosis, and CDC developed diagnostics that we then rolled out with the Ministry of Health to the hospitals, and seeing infants getting tested early and being able to put on treatment. These were amazing events to see and really had large impact. And then I think how we were able to do that is CDC is based in data, and we always use information. So if you're not collecting the data, which was under my purview, if we weren't being able to measure and to be able to follow people over time to see what was happening and when they lost a follow-up or if people died, the impact of our programs is data are the critical need within our programs.
It's really striking to me, having talked to plenty of people who worked on the ground, especially in these early days, that you're trying to collect as much data as you can. You're trying to get medication to people. But you're also navigating policymakers coming in and wanting to go on tours. And, we've heard about, the Tommy Thompson tour where there's, congressional people coming. And so what is that like to try to balance these things of, you're trying to save lives in the clinic and also convince people it's working. What is that like?
I think it's a really important piece that you have to be able to do to sustain the funding and show the value, because getting initially the funding for PEPFAR, now I wasn't in Washington at the time, but to hear how, with Jesse Helms, it was really about seeing that baby with HIV and baby dying, which touched his heartstrings, which changed his mind. So it is so valuable, because if it is so far away and they don't know what you're doing with the funding and what's happening, they can't talk to it and they can't actually have so it's so important. So we took these very seriously. One of our colleagues, Barbara Marston, in Kenya, she organized, we had 4 buses of people. And so she organized people by animal troops. So everybody got a little sticker with an animal on it. And we took people, to the clinics, to the voluntary counseling and testing, to be able to see what the funds were doing and to talk to people who had received the benefits of the U.S. government's investment. And that was very touching. Later on, we'll roll into 2017, I went with Garrett Grigsby, who was at that time leading the Office of Global Affairs at HHS, to Uganda, and meeting the woman who received the first PEPFAR treatment in Uganda, and hearing her story. I mean, I was in tears just sitting there listening to her, and it touched him and as well all of his colleagues to see that this is an important investment. This is about saving lives, and it is about health security.
When you talk about the partners that you all make to distribute PEPFAR aid, we've talked to quite a few people who've worked in Uganda, and it seems like the infrastructure in Uganda in some ways was already in place, and that they knew who their partners were. We've heard a lot about Tasso, but when you talk about Burundi or Eritrea, it feels a little bit different, that you have to build the plane while you're flying it. And
yes.
So How did you identify who your partners would be, decide who would be good implementers, especially as you said, the American policymakers want to know how their dollars are being spent.
Yeah.
So what is that process?
Yeah, and I think you raised a really good point. Is early life and GAP was about building infrastructure, because you needed to have that. You had to have all the boats rising to be able to do what you are trying to do on a long-term sustainable program. And so that was very important. So in thinking about it, okay, so you need laboratories. You need strong laboratories. You need the data systems. You need the clinicians. You need the nurses. So you sort of go through, like, what are the areas that we're trying to include, and in prevention and the counseling and testing. So we would need, volunteers. We would need counselors. And then you think about, okay, who are the partners for this? So ministries of health were a huge partner, especially for CDC. We were and still remain their, main partner for PEPFAR efforts. CDC remains the main partner. But then the value of USAID partners working with community-based organizations, civil society, because that's where in the counseling and testing, the value of that came in, to be able to get people in the community who wanted to come, who were the key influencers, who were the social efforts that could be done to be able to do this. So that was really important. But strengthening all those components were really important. And then thinking about, okay, we need a strong workforce. So we brought in University of California, San Francisco, UCSF, in many countries to train nurse cadres of nurses, so that we would have the ability to be able to how to deal with a person with HIV, put them on treatment and follow up, and develop a long-term plan, continuous of care. So these were important. So we looked at universities with strength, both internally, domestically in a country, but also globally, and then civil society, academia, as well as then with the ministries of health were really critical partners. I know USAID partners had some very large non-governmental organizations that had connections, for example, FHI 360 or some of the larger ones, but they all came down to, we still, regardless, you had to work with who was on the ground, and that was, the people from the country, and they had to ultimately own this.
Your last point that you made about we have to work with the people on the ground is one that we heard from John Blevins when we were talking about faith-based implementers, and that in a lot of places, that's the partner. And there's not you might think that there would be more, and maybe from the American mindset of there are faith-based groups, but there's also more secular medical institutions that you can work in some contexts that's not true. And so I'm curious what that faith-based partnership looked like, especially early on when you're in Kenya and Tanzania.
Yeah, from the medical side, there were a lot of faith-based organizations that had hospitals. I mean, I think I want to say in Tanzania it was up to 20% at that time, and in Kenya as well was about 15 to 10%. But they ran hospitals in rural areas. It was always not private, but it was the faith-based hospital. But these were really critical, and so having to partner with them on a technical level. I remember I was actually in Tanzania. We were out visiting a hospital and it was a sister who was there, and we were talking about the use of condoms. And this is not something that they would promote. It was very, very hard for her. So we had to tiptoe around this. But I remember just feeling a little frustrated because I'm like, do you understand what's going on? But I just still having to address that. So they were playing, so in that sense of the technical running hospitals and clinics was important. But I do know, I think too in the community, being able to, stigma was an area where they were very helpful in helping to address that as well.
It's interesting how we've talked to so many people of the interlocking approach, right? That there's data, there's labs, there's these hard scientific things you want, but then it's more, sociocultural of how do you address stigma? How do you understand, what it means to come in and make an intervention? And how did you see that as, PEPFAR is bringing all this money in and American policymakers want to see certain things, and you're also adjusting to the reality of what people need on the ground? Like, what is that process like?
Yeah, it's a dance. And also, the results that we're trying to push forward very rapidly and demanding results. And it does take an all of government. So from the U.S. side, we needed the strong leadership from the ambassador, and then the PEPFAR coordinator position was created that sat in the embassy to work with the agencies that were actually implementing programs. So that was very important, that we had a a collaboration and that we were able to work together. And then with the ministries, and it wasn't just, it was like the Minister of Defense as well as the Ministry of Health. And for USAID, which focused a lot also on the procurement and bringing, logistics and bringing supplies in. I mean, they had to work very closely with the supply chain management systems as well in country. And so there had to be meetings on this, there had to be discussions, but really, we would sometimes take, especially in Tanzania, which is a socialist country, everybody wants to move together. You don't want to go far ahead because it's just not seen as something that's part of the society. So you couldn't jump out here. You had to bring everybody with you. And so sometimes it felt like we took one step forward, and then we had to come back a little bit and go forward. But you did get there. And when you did, it was solid and it was moving forward. So there was always sort of this story is like, if you want to get something done that's going to last a long time, you do it in Tanzania. If you want to do something really innovative, you go to Uganda. It was within that sort of and Kenya could implement anything right away. But it was just sort of this, how that happened was so different. So you have to appreciate and value what's going on in the country, how the culture is, and working with that, because if fighting it is not going to lead to the results.
Tell us about your role in Tanzania. You end up back in the CDC in the country office. So
Yeah.
what was your purview? What was your job when you get into that role?
So it was covering all of the surveillance. It was covering all the monitoring and evaluation for PEPFAR in Tanzania. We also had all the workforce development. And so it was and then the capacity building. So there were large areas of sort of the infrastructure components that are needed that cross-cut all of, whether it was care and treatment, voluntary counseling and testing, the community efforts with stigma. So we needed all of this. So we worked with all of the groups. And I had a team of about 8 people at the time. And we had to serve it wasn't just CDC, but we had to work with Department of Defense, Peace Corps, and USAID in that, and the embassy as well. So it was very much, having all this information, I think, the speed with which we did it or were able to collaborate with the Ministry of Health to get these data was always sort of a tension point, because like, where are the data? What's the information? And then, as I said, working to train cadres of laboratorians, because what we found is once the laboratorian was trained, he or she went to the private sector and left. And so we wanted to create a career path for laboratorians in Tanzania. And then you have to work with the Ministry of Science and Technology and Higher Education. So it was all this sort of pieces that we would have to do in this effort. But really, we in our group had to work across all of these different areas. So we were very cross-cutting. And I would think, too, the other large role I played was in the interagency space. And so we met, felt like for hours sometimes. And it was. I mean, sometimes we'd have like 5-hour meetings, but we would sit together and talk about the programs, talk about what we're doing and who was the best place to do what and how we would collaborate. So this was just constantly occurring. But in these type of environments, you have to constantly share information, constantly know what each other's doing. And so that was really important.
What would you say when you think about this idea of capacity building? And this is something we've heard a lot from people who worked on PEPFAR and someone who's trained in U.S. foreign policy. You hear this all the time, right? Once you put the aid in, you want to build capacity. And so what does that mean to you in an abstract sense? And then what did that mean for you in Tanzania? Like, what were your, Dr. Martin's priorities of the things that you wanted to say, this is where I'd like to see this?
So abstractly, for me, it means getting us out of a job. I mean, that's what it means, is that there is the capacity for the country to lead this, to do this, and we move on. Or not so much move on, but our relationship changes. It's much more of a relationship we have where we share technical information, where we innovate together. And it's not always in that helping situation or supporting situation. So on the ground, there were a couple of things I implemented. One, which was something that CDC had done in many places, the field epidemiology training program. So I introduced this in Tanzania, and it was focused towards the HIV/AIDS epidemic and how they could help in the field, and based on the Epidemic Intelligence Service, the EIS program here at CDC in Atlanta. So it was based off of that. So we built that in country. We also introduced a whole avian influenza program. And by doing that, and that created also laboratory space for that. And that came from knowing we got additional funds to do that because of the laboratories that we had built and collaborated for HIV. But training, again, building that capacity for avian influenza was so important. And the Tanzanian government very much wanted this, as well as at that time there was a lot of avian influenza there were some outbreaks occurring and they wanted to make sure they were able to detect it. But it built that capacity. So now, I mean, today when they were facing Marburg a couple of months ago, when they faced that, I mean, they're able to have that capacity to respond to that. And so I think that's the first, I mean, I always believe even in COVID was building the workforce so that people are on the ground to do this. And then having the abilities to do it through the laboratory, through their abilities to work through facilities. Yeah.
What would you say when you think about, that time of your biggest challenges, the places where you said, we kept chipping away at this rock, but it just seemed to stay the same size. What was that for you?
It was actually implementing the whole data scheme for being able to monitor treatment. And getting data to flow, being able to follow patients over time. As I said, you wanted to know if they would get lost to follow-up or what happened if they moved. Knowing if somebody moved from Iringa to Dar es Salaam, we weren't able to track that. So it was really about how do you creating a whole data system for this, for the country. We worked closely with the AIDS program at the time, like, how do we do this? And how do we make sure we're capturing and that we're not overcounting, we're not undercounting, and that we're making sure we're capturing everybody? That took a lot of work and a lot of revisions of like, okay, now we do this. And then everybody's like, let's introduce technology because that'll solve the day. And I'm like, if you can't do it on paper, you can't do it with technology. We had to have the system. And then, of course, technology is fabulous and you can bring it in, but it doesn't solve the problem if you're not able to first get those data and understand what you're trying to capture, and training the clinicians in the clinics or in the hospitals to capture these data and to write it down or to put it into the system was really, that took it took some regulations and policies from the AIDS program to do that, and to make sure that we could capture so we would know what impact we were having by doing all of this.
After you are in Tanzania, you serve as a regional advisor for immunization in Europe. And I'm curious what things you brought from your PEPFAR experience to a very different role, completely different continent. But we've heard a lot about how PEPFAR changed the way people did their job, whether it was in the CDC or elsewhere. And I'm curious what influence it had on you as you took on this new role.
I would say the biggest thing is the incredible amount of partnerships and how you bring it. I think, it's interesting you say it because I think that's where I sort of developed my value that I still hold today is about the multidisciplinary approach to health, and that actually 80% of health does not occur in health. It occurs in other sectors. And you really need to address these to be able to solve your problems, the quality of the services you're providing. So that was really important. For example, in Tanzania, we worked with the Jane Goodall. We worked with the gaming industry to develop games for adolescents. And so all these sorts of things about HIV and so that there would be the education component. But I would never have thought of all those things before. And so bringing that into Europe, I was brought in to work as the regional immunization coordinator for 53 member states. And while they had a measles and elimination goal at the time, there was measles raging across the entire European Union and the Central Asian republics, everywhere, Eastern Europe. And thinking about some of these capacities that we, especially adolescents, like how do you reach them, university students. So those things that I had learned through PEPFAR, I brought about like what types of partnerships we needed outside of just ministries of health, and how we were going to do that was so important.
I love the phrase that you had about 80% of public health is not actually in health. And it's really striking to hear all these different ways of, the game. I'd love to hear more about the game that was developed. What is that?
Yeah, I'm trying. So we worked with Sony at the time, and they developed, the here's my age, but the games the kids played with, with
like a Game Boy?
Yes, thank you. And so putting games on there about HIV prevention, so they would make choices like this is happening in your life, and you could do this or that, and so you would pick this, and that's how you're, what would happen next. Okay, so now you're being exposed to HIV. What are you going to do? And you have to make a choice. Like I'm not going to have sexual relations, or I'm not going to do this, and so then they would take them different paths. But it was they put it in a gaming sense so that adolescents would be interested in learning about HIV too.
It's really interesting to hear from you the balance between what you see on the ground in terms of prevention, right? And then putting drugs in bodies, which is what we heard was one of the real things that was the push from Congress, was they wanted to, I think one of the quotes that we heard was pills in bodies, that they wanted to know that. And so What does that feel like on the ground of trying to balance these two things, especially when you're thinking about interventions in children and creative strategies? Like, what does this look like in practice of resource distribution?
Yeah, so that's a really good question. And to me, it is the ultimate of getting people on treatment. I mean, and we found out, I mean, Kevin DeCock was an early adapter, and it took him a long time. He was saying this when he was leading HIV at WHO at the time. We need to get treatment as prevention. And so that really that needs to be sort of the number one thing that you're going to be funding. And I do believe that. I mean, some of these other efforts are very important, and it's catching the early age cohorts about prevention. But if you're really going to focus, it's about getting people on treatment and getting people tested so you know if you're HIV positive. And if you're HIV positive, are you on treatment? And then are you going to stay on treatment? And based on that, how many people stay below levels of detection so that they're not spreading the infection?
What does the reporting structure for that look like? How do you know what metrics you need to hit, and how do you build something like that?
So this is where sort of the 95 came out of, and from working with UNAIDS and working with PEPFAR together, developed this about being able to detect if you're interrupting the epidemic. And so then you have to think about what are your data systems around? How are you going to know how many get tested, and of those who get tested, who is positive or not? And those who are positive, are they on treatment? Do they stay on treatment? And are they below detectable levels? So it requires the constant viral threshold testing. But you have to then develop your system. And I think this is one thing that PEPFAR did, which was the data go down to the facility, to each individual patient. I mean, the amount of information and data that are collected is just phenomenal. And it's used. It's not that it's just collected and put in books. I mean, these data are used and poured over for really making sure at the local level what you're doing is making a difference and that you're able to capture people. It also helps detect, like if you saw all of a sudden a lot of cases that were not below viral level threshold to be detected, there could be an outbreak occurring. And so then you can bring in, like, what are we going to do to respond to this? So using those data are so important at all levels.
How do you scale up something like that? You talked about you trying to reach a rural clinic and training people to be able to do this and convince people to come back. What does it look like to scale something like that?
It looks like you don't sleep. And you have very strong, looking at Ambassador Birx, Ambassador Gooseby, and working also with Ambassador Dybel, all of them were very driven to making sure that we could show impact for this. And so doing the scaling does take time. It's not something you can do overnight, but it does require building on infrastructure or systems that are there, first of all, if they exist. And if they don't, how do you create them and make sure that there is a sustainable future for them? I think that's really important. And sometimes we did forget about the sustainability. And we have replaced budgets in governments, for health as well, and making sure that we're engaged. But I think it's really important that we look at that sustainability piece to make sure that this can continue. But the scaling requires, building up the workforce. It requires building up the laboratorians, as we've talked about. It requires the education. But on the other side is getting people to use these data and making sure people understand what they're seeing. And so that was the other piece of how do you work with parliamentarians? How do you work with US Congress to make sure that these data are understood and the value of the impact that it's having? So it's got to be on both sides, collecting it, but then also being able to use it in a way to further impact the program for scale up.
What does a funding life cycle look like, right? Because, we've heard about the COPs, we've heard about, how you have a plan and you put it into place and it goes through 5 months of revision. So what does that funding cycle look like of how you go from, we want to put this program into place? How do you run it up the chain? What is that mechanism?
Yeah, so if you want to introduce something new, it had to first then go through the whole country operational plan series and be brought forward. So it did take time that you had to get it in there. And then, so if I'm at CDC putting this in the COP, it has to then be vetted by the entire PEPFAR community. So it wasn't just me saying I want this in the COP and somebody at USAID say I want this, because our budget levels are set, and so it's like we have to work within this budget. So you have to put this in. And then when we'd all come together, there was intense scrutiny on your proposals and your country operational plans. We would be shaking our boots, I mean, sometimes, especially with Ambassador Burks, because it was so detailed. And what I really appreciate about her, though, is she brought civil society, she brought the UN, she brought WHO, she brought countries, and then us as the partnership as USG and private sector sometimes, to all look at this together. So it was not done by the US government secretly in a certain way, but it was very open with input and also the value of this. So that's what you have to kind of go through. And then afterwards there would be a signing off on the COP so that you could move forward with the funding. But it took, first internally with your agency, then cross-agency with the governments, with the host government that you're working with, and then taking it forward to the larger regional or global meetings that we would have on the COPs.
When you talk to us about, we joked about decision making in Tanzania and how you got the collective together.
Yes.
And when you came into Tanzania, did you have a sense of the state of the epidemic, and then the areas maybe where things were going well, or there was already strengths in certain areas? Like, what did those look like in Tanzania specifically?
Yeah, I think most was, if you looked at the big urban cities, so like a Dar es Salaam or Arusha, there were things occurring, but was it as developed or as capable as it could be? I think there was a lot of room for improvement, but especially in some of the rural areas. Zanzibar also had a very large injecting drug user problem. And so thinking about, we helped create a program for Zanzibar about prevention too for injecting drug users. So all of these different things were put in place, but they weren't there at the beginning. And there was a lot of stigma and a lot of fear. And I think our Tanzanian colleagues that worked at CDC also, who had been on the front line before coming to work at CDC, were very frustrated because they didn't have resources, they didn't have treatment, they didn't have things to be able to bring to bear to fight this. And they saw more and more people dying and just trying to comfort, and more palliative care was occurring.
You talked to us about all of the different groups that you are liaising with in this role. You're having the 5-hour meetings, right? You're talking to every parliamentarian that you might need to, the Ministry of Health, you've got civil society, you've got faith-based groups. How do you break into a local space like this and gain your footing? How do you build trust? How do you get them to see that meeting with you for 5 hours will be fruitful? And what does that relationship building look like? Yeah, no, that's really important. And I think once you have that trust that's built, it serves you well for everything. Because even when there were other outbreaks, the government would come and tell us, well, we're having an outbreak of this, can you help? Or can you support us in the laboratory for this? Whereas before, we wouldn't have that. And I think that's the value of what CDC has built around the world with different countries, is that relationship that allows you, hey, we're having an outbreak of this, alert, so that we can figure out how we're going to protect Americans here. So that's been really important. But to develop that, it takes time. I mean, just as, developing any sort of a relationship, it takes listening, it takes talking about what are their priorities, what are their needs, how do we match with what our mandate was coming in to figure out how to collaborate with them. And it takes showing up and being there. I sat for many hours in front of the chief medical officer's office waiting for a meeting. He can see you now, and then I'd have to wait, but I'd sit there for 2 hours to wait to be there for him and to support what he was trying to do at the time. Because that's really what it takes, is showing that we're in this together, developing, co-creating the plans together, and making sure that we can address what their needs are. And sometimes they were put in tough positions, and there was sort of a head-on sort of collision in that sort of sense of like, what are we going to do if they were not able to say the minister's not going to agree with this? We had to figure out how to work and collaborate. So that was really important to do. I'm curious how, navigating that dynamic. I mean, there's been a lot, whether it's in people talking about public health, of, questions about what it means to put so much American money in, and is it just going to be the Americans coming in and dictating, and countries don't want to be seen as just taking orders from the U.S. And so, what were the priorities for, the players that you're working with in Tanzania? What did they really care about, and what did they want to see? And were there places, was that totally aligned with the U.S., and then places where it was not at all?
Yes. So I think when going into Tanzania, the ministry really wanted primary health care, wanted to establish health care at all of their facilities around the country and to be able to serve the entire population. Now, the HIV epidemic was not everywhere in the country, and so we were not focused on every district or province in the country. And so at that time, thinking about how to balance that, had to have some discussion because these monies had to be used for HIV. And so saying that, you can use this money for some non-communicable disease interest, that didn't work very well. And so there was some take and give on that. And there was some conflict, discussions about how to do that and discourse. But I think recognizing that they did have such a huge epidemic, the impact on their economy, they understood that, and this was a very important priority to them, and still remains to be one. I think that's where the value came. What we were able to do, thinking about the pink ribbon, red ribbon, where I started to think about breast cancer, cervical cancer, those types of things came up, and also with tetanus and sort of thinking about how to vaccinate men. All these things sort of came out, and that's where the opportunity is like, okay, we can address this in a larger way of thinking about your primary healthcare efforts, and bring this together and collaborate, but PEPFAR cannot pay for all of the efforts. And that was the important piece of like how to partner and integrate, but not be able to pay for everything. Yeah.
One of the things that you mentioned earlier was this the sort of urban-rural divide, and I'd like to circle back to that a little bit of like what were the differences that you all saw between what you were kind of trying to build up in the urban context and what you were trying to stand up in the rural context?
Yeah, and it's always easier in an urban environment because you have much more access to materials and infrastructure. And so in rural areas where we knew it was important to understand and to learn what the epidemic was and what levels were, you have to think more about how do you do this remotely? How do you get people on the ground? So training people on the ground is really critical in this type of environment. And then how do you start to ship specimens? All the the logistics and transport issues come into play that are very important. But it was an important component, and I think the ministry wanted to see all of their country covered. And so how do we do this? And so that was the value of thinking about that. But I think the urban areas require more funds, actually, for per person detected, because of the effort that's required but training people on the ground was most important so that they could actually carry out. And then you use remote communication. I just think of one story with Dr. Masiwa, who is the chief medical officer. We were sitting there, and he says, this phone, the fishermen, before they leave the waters, they've sold all their fish by the time they come in. He goes, and I don't even know about this outbreak that's occurring of influenza in a certain province because I don't have that information. So how do I get that? Because it's a remote area. And so it was, again, thinking about how do we use technology here to actually improve the communication, to get information flowing faster, and in real time to be used for program input. And that's required more of a rural area effort. Yeah.
What would be the balance between that you would say of, I'm making an assumption in the rural areas, you're probably working with a lot more, grassroots partners that have that reach. But maybe there are more, international, American NGOs. Like, what is the balance of, the numbers that you were working with? Were you working with mostly grassroots? Were you seeing a lot of different American partners? You mentioned Jane Goodall's group, which is a more international organization. Like, what's the balance between those kinds of groups?
Yeah, I think that shifted over time once there was capacity built, that it moved more from international non-governmental organizations to local NGOs. But even the internationals always engaged, and most of their staff were from the respective country. And they were from those areas, because you can't send people, even from one province to another, you couldn't send people to do the job, especially on something sensitive. So it required somebody from the community. So we saw more and more where the international NGO role became more of an advisor of building that capacity and handing over, whereas early on, they were much more on the ground implementing alongside their Tanzanian counterparts or Kenyan, yeah.
When you go on a, like a site visit, like tell us what that's like. What are you looking for? What are you trying to evaluate and see as you're coming down from, the CDC, what they're looking for. What are you looking to see when you go on these site visits and visiting these partners?
So the big thing is, what impact can you show? And when can you, so the laboratories are good. So here is a laboratory that can detect HIV. It can do TB. It can do, and most of them, they were doing measles as well because it was the same ELISA machine being used. So flu. So, I mean, the ability to show here's what was built by HIV and is being used by this local level to be able to detect all these other diseases and to be able to stop and prevent them before they spread. So laboratories were always a really important thing to show about the capacity built with the laboratorians. The other is the clinics, being able to see how a patient is treated from coming in, what's the process for getting drugs and being seen and then being treated and then coming back and hearing the patient's own stories. I think that's the heart and mind component of it, is being able to show that this person is so appreciative of being able to have access to drugs and treatment, and it saved his or her life. And so that's very important to show too. And the counseling and testing, I think, as well as being able to see how that works. So showing what the money is going to and the impact it's having on what you're doing, looking at the data books to show that we're able to detect people, we're able to put them on treatment, and look, people keep coming for treatment, was really important to show those efforts, yeah.
When you have, you've got all these different sub-grantees, and I'm just thinking about this in terms of like, if I'm an employee and I'm not doing a good job, you get put on a performance improvement plan. Like, what do you do when you have a clinic or hospital that's not meeting the standard? Like, what does that intervention look like? I'm sure for ones that are great, you're like, keep going, great work,
Yeah.
But for one that's not meeting what you all need it to do, like, what does that process look like?
Yeah, so CDC, we would have cooperative agreements, which are a little bit different from a grant because they require that you also provide technical collaboration. So it's not just giving some money, funds, and then asking them to perform. It really is that we develop this together. And so we did have those regular touch points. We had a lot of what public health advisors played this role of doing the accountability and the monitoring. And if goals were not being reached or objectives were not being met, going to sit down, and we would have annual reviews of looking through programs. But the day-to-day, like a specific staff, we would have the partner or the Ministry of Health or whoever owned that facility work on that. But it would definitely be like, what's the issue about trying to achieve this that we're not? So it was really important to continue to have that frequent monitoring, evaluating the program, and working with the partner hand in hand, which allowed us to have those day-to-day interactions and changes.
You mentioned earlier the mother-to-child transmission,
Mm-hmm.
and one of the biggest pieces of PEPFAR is the impact on women and girls. And so can you tell us a little bit about what that looks like specifically for you in Tanzania, what you all were really focusing on?
Yeah, what we're trying to make sure that they were getting seen and tested beforehand, and that they were then also getting put on treatment. And so that was, and then the early infant diagnosis was something that was introduced as well when I was there, and that was a really incredible important point afterwards, so they could test the infants. But making sure again that there was put on treatment beforehand, and that they were able to do this. So that was sort of what we were trying to make sure, and that we could follow the women and make sure that they did come in, because many times women only come in for one antenatal clinic visit. So how do you increase that? How do you follow them? How do you follow them into the community, which then required a civil society approach to how do you engage the women to make sure that they come back to the clinics for testing and for treatment. So that was a continual effort to build that going along. And I think, that's one thing that also very much attracted when we had visitors was the PMTCT programs, being able to see that. And the mothers would come together at clinic and have other activities, and they would have sessions. We would see, I know, I was there once, and they were having session about how to cook nutritious food. So there was always the build on too of like when the women came together, it was like, how do you also improve the health of them and their children as well after birth?
It's interesting that you talked about that in terms of, I'll say like a whole life
Mm-hmm.
for these women. And it's something we've heard about PEPFAR that you kind of touched on of once you start improving things like labs, they don't have to just do HIV testing. They can do all these other things. And so from when you get to Tanzania and when you leave, how did you think about how the system had transformed when you leave? Like, what were the changes that you saw at the end?
Yeah, I think some of the biggest changes was the mindset on, infected people on treatment, keeping them on treatment, and how to do that. But then all the things that go behind that. So the laboratory piece, the how to get the drugs in time into facilities, all of those components that have to work. That was all just coming together and putting together, and having nurses that could do this work. I mean, seeing all of this sort of come together in a real time and have to mesh, and actually the impact is greater than just the pieces. Is just phenomenal to see that, and the country really owning this piece was very valuable to see that as well. Yeah.
When you think about that time, what are you proudest of?
I think I'm most proudest of starting the FETP, the Field Epidemiology Training Program, because that is still going strong today. And I also think about the value of the importance of the laboratories that we put in place. Yeah.
And after this, you go to Europe, and then you move into leadership in the CDC. And so in 2012, you become director of the Global Health Center's Global Immunization Division, and then eventually it's overall director. Could you tell us a little bit about what is the Global Health Center at the CDC? What is it? What's its purview?
So it was established in 2011, 2010, around then. And it was late 2010, early 2011, and came together under previous director Tom Frieden, who saw global health work occurring across many of the different centers at CDC. But the value of bringing all this together, because of the work that CDC does in capacity building, laboratory, surveillance, workforce, emergency operations, that was cutting across all the centers. So could we be more effective bringing this together? And then we had some very specialized programs. We had PEPFAR. We had the global immunization work with polio eradication, measles elimination. We had President's Malaria Initiative, and then the workforce. So trying to bring all this to NTB, so trying to bring all this together into one center, not to be the only place at CDC where global health work is occurring, but how that could also be the value, because many outside partners would say, we don't know where to intervene at CDC because there's so many different points. And so how to bring that together. And then also, how do we get more of a strategy for our global health work? And that was critical, because there were 1,000 flowers blooming. And so how do you start to think about what is CDC's global health strategy? And with PEPFAR, it really gave an opportunity for CDC to have long-term presence in countries. That was really the opening of our country offices. And with that, there's a lot of management and operations that goes with that, and that you have to have some people working specifically on that. And that was nowhere to be found within CDC. So it was really having dedicated people start to work on how do you manage and operate an office overseas? How do you support the embassies? Because we became much more, we were under the embassies, and we had to be much more accountable to them, and the value of the work we were doing, and to be a partner within the U.S. government under the embassy leadership.
I want to drill down on a point you mentioned about how PEPFAR changes the CDC. And we've heard a lot about how PEPFAR changes the countries it operates in, but PEPFAR also changes the CDC.
Yeah.
And as someone who was in CDC pre-PEPFAR and now during PEPFAR, what were those changes that you saw, especially once you're in this leadership role?
Yeah, I think it gave us a bigger seat at the table to really bring our expertise and knowledge to bear. I think that is the biggest. And before we worked through, as I mentioned, we worked through USAID, we worked through other organizations, but we didn't have the presence that we did being at the table. And that really changed for the U.S. government, for us to be at the table and to show the value of what not only CDC, but you had HHS, what all of that could bring to the table, and with HRSA and different groups as well, the importance of that we could be there, the value that we had, the experiences here, and the value of what's been done in the United States, what we could help bring to the globe.
And when you're in this role, I'll call it PEPFAR is a mature program, right? It's been over a decade old, and versus when you're there initially and you are trying to literally get people on medication.
I was at both ends. Yeah.
And so, when you were in this role in 2012, and what are the changes that you've seen, and what are PEPFAR's priorities at that point? How does it look different than when you started?
Yeah, initially it was about the infrastructure building. And so funds were going very broadly to build capacity, for all of the different things that we've talked about so far. So it was really about the infrastructure and getting all boats to rise at the same time. Now coming back, it was very much focused on HIV indicators and controlling epidemics, interrupting and reaching epidemic control. And how do you do that? So those are the more important things coming up now is who's infected? Are they on treatment? What are their detectable levels? And finding new ways of, now we realize that treatment was prevention. Is how do you do that? And then PrEP came out. So there was much more, but it was much more focused on the HIV component of what we were doing and less trying to build the broader, recognizing that a lot of it was still there and sustainable. And I don't think a lot of that's known about what PEPFAR built in terms of the health systems for countries, but it's and maybe some people would be concerned about it, but it really was about the health security, because during COVID, it was the labs for PEPFAR that were doing all of the testing for COVID as well. And and there's many stories of that too for the TB as well. But I think it's really important, the values of what was built, and now it was much more honed in on looking at which populations were, which areas in a country. It wasn't the broad, like we're going to cover the entire country. It was very focused, and we had to be very, skilled at what we were doing and talking about what our impact.
You mentioned the health security piece, and that's an early justification that the Bush administration uses for why PEPFAR, that it was a national security risk. And, in sitting in that seat that you were in Tanzania and in your role at the CDC and leadership, like, what does that actually mean for for a disease to be a national security risk? Like, what does that feel like on the ground? And then what does that feel like in leadership?
It's because I truly believe this. and I think health security is national security. And I feel so much that we in health talk in an echo chamber to ourselves. We go to meetings and we're all talking. I'm like, yeah, this was said 3 years ago. We all agree. Okay, yes. But it's like, how do we break out of that and the importance? So in a country, what I would want to do is to bring in other ministries and to get how do you get the Prime Minister's office attention? What could you do to do that? Because it was so important that we had recognizing what the impact of health is on X country's economy. So in a country, it was really thinking about outside of the Ministry of Health, what could we do to bring other sectors, the higher education, what was needed from the Prime Minister's office. And that was done a lot with Global Fund, being able to reach with the portfolio. But I think that's an important piece in country is really, and sharing the data in a way that they can understand. Putting a bunch of graphs on front of their faces is not the way we're going to do that. But how do you talk about the return on investment and the economic impact if you don't do this? And then at the global level, again, it's really being in those fora where security is talked about. So getting at some of the G20 meetings and really putting health on the agenda. That's something that we saw over time. And on the UN General Assembly, the high-level meeting about getting health topics on there. Yeah, so at the global level, it was really about how do we get health in front of decision makers at a national security level, and the G20, G7 meetings, as well UN General Assembly high-level meetings, et cetera.
The point about reaching decision makers who may not have the same priorities as you, especially when early on you're navigating Tommy Thompson coming, and now in this role you sit through different administrations, different presidential administrations in the U.S., different global priorities. How do you navigate those things in a leadership role where you're still thinking about how do we get this to work on the ground, but how do I get them to buy in? Like, what is that like with these different people, priorities, stakeholders?
You really have to look at what are the priorities of the administration, and what are they moving forward, and whether it's going to be about the security of the United States. And we love to say, infectious diseases don't know borders, they have no passports, they can just come. So, I think talking about, in that sense, when you're talking about security, is like, how is this important to Mr. and Mrs. Jones in Akron, Ohio? Like, what is the value of the U.S. government investing in this, and showing them? So we did a lot of work at CDC when I was there on showing, for each state, we developed a profile on the impact on trade, commerce, and how many international organizations or businesses were in their state and what they were connected to. And if there was a pandemic, epidemic, what would be interrupted and the impact on the communities. And then the third piece is always people care about their future children. What's their children's future going to be like? That is something across any administration. People care about their children's future. So that's sort of how do you think about appealing your program to those and the value. And infectious diseases fits well in, if you're thinking about maternal and child health, or if you're thinking about health security and protecting the U.S. borders, it is really important about, stopping diseases where they start.
You mentioned earlier about kind of identifying the strategic priorities and the strategies. And I know the CDC now has 4 core strategies for ending the HIV epidemic: strong partnerships, dedication to eliminating stigma and discrimination, ensuring access to quality people-centered HIV service, and that treatment and prevention reach disproportionately impacted populations. And I'd love for you to talk to us about each of these and what you see as kind of, if we're looking at this now in 2025, like what is going well in those areas, and then what are the challenges, especially globally, to reach some of these impacted populations?
Yeah, and I was recently with Georgetown O'Neill Institute, Emory. We worked on the Visioning 2031 because this is when epidemic control is going to be reached. No, we're going to end the epidemic. And I think while continually to stress all the great progress, I don't feel we gave enough of a warning too, is like, we're not there. And that's so important. And across all 4 pillars that you mentioned, the work still needs to be done. And if you're thinking about stigma, the work with the community-based organizations, faith-based organizations is so critical that it's not something you do and you stop. And so how do we think about the continuation of this work and the sustainability of it, and not losing those structures that were built to help move forward at the beginning? There was a lot of advocacy for this. There was a lot of effort, which has sort of thought, okay, it's moving along, we don't need this anymore. But we need to bring a lot of that back and to keep the communications and keep telling the stories about people on treatment, people who are not getting treatment still. I think one of the things you mentioned, the patient-centered care, that came about because people weren't coming to facilities. And it's like, okay, so why aren't they coming? So you have to think about differentiated care. How are you giving care? It can't only be in brick and mortar. Like, you have to think about, can you give it at the side of the lake? Where can you be and set up pop-ups, or what's going to be needed? So this continual work needs to be done in these areas. But I think there's a lot of progress that's been made, but it could be lost if we don't really take this seriously and recognize that there is still work to be done, and we all need to do this together.
Are there things that you would say with PEPFAR, kind of thinking back on whether it's your time in Tanzania or in these roles with the CDC, that you say, that was a missed opportunity. I wish that we had drilled down more there. Are there things that you would say, PEPFAR obviously was a ton of money, but are there places where you wish, we could have done more in this kind of way?
Of course, you always think, and you wish, if you'd had, more people, more trained efforts, more funds, that you could get more people on treatment. And I think that's the biggest thing is, getting people tested and getting them on treatment to stop this epidemic is really critical. One thing I'd say at a higher level, which I still feel too, is the sustainability. That needs to start with day one. And really thinking about it. When I was, you asked about the Global Health Center. When we brought these 4 different areas together, the immunization, the malaria and tropical diseases, HIV, TB, and workforce and development, when we brought these together, it was really to think about all of these need to work together. There needs to be integration. These cannot be siloed because there's so much more to be done here. And the sustainability of what PEPFAR is building can be used for malaria, and can be used in immunization. What they've done in reaching every child in every community can be used for HIV. So it was really thinking about how to bring those programs together on those efforts and think about building the sustainability together, and not to try to do it at the end and then you say, okay, country X, here's your program, now you take over. There's so much funds involved, and there's so much of the workforce that without doing that from day one, you are setting it up to, it's going to be very difficult to take over at the same level without those funds being there, or at a lower level.
Today we're sitting at Emory, and we're at Emory's Global Health Institute, where you're now the director and the vice president for global health at Emory. And What role do you see universities playing in the PEPFAR story, whether now or in the future or in the past?
Yeah, universities were critical, and I would say both outside of, like if we think from the global north, but also the global south. And I think even more now, global south for south to south opportunities for growth and for, the continuing of the capacity building is really important. But where I think, and it's a bidirectional research opportunity where we learn some of the problems from the field and like what can implementation science or research do to help solve those, but as well, what research is occurring that can really move forward. I mean, rapid diagnostics, long-term treatment patches. I mean, all these types of things where this can be done together is so important, and that there's that bridge between academia and with programs. And it's, as I said, it flows in both directions to be able to find out what the problems are and how to solve them. And I think they play a critical role because it brings a different community together that really can help direct also the research that's needed to make sure we achieve epidemic control.
When you reflect on your involvement in PEPFAR, how do you see that it impacted your life, personally or professionally?
I'll go back to it impacted both. And I would say first professionally about my belief in a multidisciplinary approach. And with the Institute here, it is all of our efforts, we work across the 9 schools, and it is about multidisciplinary approach. Everything we do involves students from theology, business, law, nursing, and public health medicine. So we really make sure that whatever we do in our work brings together the different disciplines. So that's something that has stayed with me since PEPFAR, and the importance of different partnerships and working across sectors as well, I think is really seeing the value of working with private sector. These are their workers. They want them to be safe. Those are also the people getting HIV. So making sure that you make that connection and see how to be engaged with them to understand and make sure that they're educated and aware. So that's been it. Professionally, personally, it's been incredibly rewarding to see what has been accomplished with, it's the largest health effort ever by the U.S. government, and to see what it's done to save lives, even one life, but to save millions of lives has just been incredible. And that's been very, very rewarding for me and my beliefs of why I got into public health and the value of, human lives and saving them and everybody having access to care.
We've heard a lot about the bond that brings people together who worked on PEPFAR or HIVs, and do you think that exists? And what does that
definitely.
mean to you?
It definitely exists. We still have parties and get together. We still do, and just to talk about what we're doing, it really, these were trying times, and as you've said too, it's like, how do you scale up building things together? And it's not just among the Americans. It's with all the countries that we've partnered with and the people there who are now leading their programs. For me to see people that I worked with now being directors of their programs is just incredible. So there is that bond of having known what we've gone through together, that it was in the effort to save lives and what we've accomplished. So it does, and you still call on people to ask advice, to ask what you're doing, can you help us with this? And we've got this issue, can we think about that? So it really does keep people together, yeah.
Are there any aspects of the PEPFAR program that you think are misunderstood, and what would those be, and maybe whose voices do you think are missing from the story of PEPFAR?
I do think more and more the communities, and I think we hear that in the respective countries, but I don't know if we hear about that, the value of what people have received. And those are important stories because those are the lives that you're touching. I think one of the things, and we've talked about this a little bit, is that I don't think it's recognized all of what PEPFAR built and to continue to build, like for the health security. And what has been built on that, and what that's just tripled in time of what's been accomplished. And so having countries, their own abilities, which is the goal, to be able to detect their own diseases, prevent them, and respond, we see more and more of those happening. And I think that story is not well told because it was never to go in and stay forever. And I think that's the important story. And then the other one is that this is not over. And we still have work to do, both here in the U.S. and globally, and we're not done.
One of the things that you mentioned earlier, and we've kind of talked about it, of the sustainability piece, and that you in those first days when you hear about PEPFAR saying, how long are we going to get this funding, right? And so PEPFAR has always, faced some level of congressional, discussion, whether it was more bipartisan passed or there was more discord over, how much funding and where. And so we've gone through 20 years of reauthorization. It's going to come up again.
Yeah.
What do you think about the future of PEPFAR and what that is going to look like over the next, as you said, 2031?
Yeah, I don't know. I worry about that, but what I do hope it looks like is that it is continued, because we are close in many places, and the need to achieve these goals that we've put in place are really important for the security of the world. I mean, we know, we've seen countries like when they've stopped working, things have slid or rates have increased. So we know what can happen. So I do hope that funding will continue. I hope that there will be a specific initiative, that it will get reauthorized, because that's important. It is an important step in this process for the value of what we're doing. And for people to understand that means that they do understand it and value it, and then the importance of continuing this to really drive forward, because I think many times we get along in a way and we're like, oh, this is good, we can move on, but we can't move on this. We're still there and we need to get through this.
Okay. Dr. Martin, is there anything that we might have missed that you want to talk about more? Anything we didn't ask?
I think we've talked about this, but I think I'll just re-emphasize what a great, the American people investing in PEPFAR, what a great world achievement it has been. And it did stop countries from sliding into negative population growth. And it did save lives and has strengthened economies. And I think this is so important, that this was a very valuable investment, and that it's not done.
Thank you so much, Dr. Martin.
Thank you.